use of indications for the expanded endoscopic endonasal approaches, thinking and enacting the reconstruction techniques becomes just as important. And so to discuss hydroxyapatite reconstruction after EEA is Dr. DOO-SIK Kong from Korea. Welcome, Dr. Kong.
Yeah, so can you hear me?
Very well, and see your presentation.
Thank you for your introductions. My topic is dual applications of hydroxyapatite cranioplasty combined with the NEUROSURGEONS flap following the endoscopic endonesia surgery for suprasellar lesions. My name is DOO-SIK Kong from Seoul, Korea. And nowadays, NEUROSURGEONS flap has become the workhorse flap for the endoscopic reconstruction of the skull base surgeries. And since Haddad introduced this technique in 2006. And this technique has been popularized by Pittsburgh group. And recently, UPMC groups reported and analyzed their retrospective data from the 1997 to 2012. Their studies shows the marked decrease of the CSF leaks, and since after introduction of NEUROSURGEONS flap from 36.5% before septal flap and to the around 9% of the CSF leaks. But still, we have to keep in mind, still around 9 to 10% of the patients still experience the CSF leaks even after application of NEUROSURGEONS flap. We experienced a very similar outcome even after the NEUROSURGEONS flap applications. We still experienced the 14% of the CSF leak. And also they analyzed their data, and obesity group and lumbar drain hydrocephalus had a very significant prognostic factors to predict the CSF leaks even after the NEUROSURGEONS flap. And also they performed prospective data dividing the drain group and no drain groups, and they confirmed that drain group has much more the improved surgical outcome, reconstruction outcomes compared to the no drain group. But still, you have to keep in mind, and the drain group shows the around 8% patients still, I think this is still a high percentage of the CSF leak here. And it means that the flap alone cannot satisfy our requirement and patients the quality. So we need more adjunctive methods. We developed the dural clip techniques even after removal of the tumors, and we applied this is a vascular clips, maybe around 3 millimeters, and general surgeons use it, vascular surgeons have used it, and we applied this beta clips to close the dural lips between the frontal dural and arachnoid membranes here. And it can be combined with primary sutures or gasket seal techniques, or finally, we can minimize the use of the septal flap here. And also, we developed the hydroxyapatite cranioplasty techniques. This technique has been widely used in the retrosigmoidal approaches or transcranial approaches, but these techniques should be very carefully performed in the sphenoid sinus, because the direct exposure of the hydroxyapatite to the air within the sinus can develop the inflammations or infections. To compensate these advantages, we combined the hydroxyapatite implantations and also combined with the NEUROSURGEONS flap. The background is here. Tuberculum cellular meningioma or craniopharyngioma are challenging skull-based tumors. And for the reconstructions, we combined the dual reconstructions using the hydroxyapatite cranioplasty, combined the NEUROSURGEONS flap. We can avoid the post-op the lumbar drains. This is a surgical techniques. Even after tumor removals, we first place the collagen materials in lay graft, and fascia or allodermal graft can be done on lay graft. And under the drying conditions, we place the hydroxyapatite, injected hydroxyapatite, and then finally, after hardening of the hydroxyapatite, we place the setter flap. Setter flap can separate the exposure of the hydroxyapatite to the air. This is the Duragen, and then place the allodermal graft material, and then we place injected hydroxyapatite, and finally we can apply the setter flap to cover the whole hydroxyapatite. This is post-op series scans. You can see, you can find the hydroxyapatite completely reconstruct the bone defect, and this is the MR imaging shows the enhancement of the setter flap. This is the rhinological follow-up findings. There was no problems, and setter flap is here. And we published, and our colleagues and our other groups has been published this data. But the major problem is that still we didn't have any long-term follow-up of these techniques, because the hydroxyapatite can be regarded as a foreign body reactions. Many ENT doctors worry about that. So hydroxyapatite provides rigid support. The setter flap helps mucosa healing, and we can avoid the lumbar drains. But still, we need more long-term follow-up data. We performed the 2-year follow-up data, and to focusing on the post-op CSF leaks, infections, and recovery. And we performed multi-center retrospective cohort studies for 190 AD patients undergoing the endoscopy endonesis surgery for tuberculous cell meningioma or craniopharyngiomas. All patients received hydroxyapatite cranioplasty and the flap. And we've confirmed that only 3 patients experienced post-op CSF leaks. The CSF leak rate was very, very low, 1.5%, and 5 days median hospital stay. No patients required lumbar drainage, and only 3 patients experienced infections, like the aseptic meningitis, and 1 cases of wound dehiscences. This is a post-op series scans, as I already shown that, and this is the 3D reconstruction technique, and then 3D reconstruction CT scans is a complete healing of the bone scan. This is a Oscar video after removal of the craniopharyngiomas, and then we place the Duragen and allodermal graft materials, and with the takusis, we keep the dry conditions, and then place the hydroxyapatite here. After hardening of the hydroxyapatite, we place the setter flap. And final view is the rhinological view. And this is the second year follow-up. During the 1 year, second years, we confirmed the complete healing of the mucosas. In conclusion, dual reconstruction technique is very effective. We recommend the broader adoptions for suitable skull-based tumors, but we have to keep in mind exposure of the hydroxyapatite to the air. It may necessitate revision surgery. Thank you for hearing me.
Thank you very much, Dr. Kong. Another very elegant presentation and technique and the evidence for it. Thank you. I will now hand over to Dr. Mack and Dr. Sankla to lead the discussion on this great session. So over to you both.
Thank you. Thank you very much. They were all indeed very good, high standard publications, papers. And the technique they have described was superb. I don't think anywhere else in the world you are doing it differently. Dr. Lima, I just have a question for you. In most of the pituitary ward, the surgeons are really planning to remove the medial wall of the cavernous sinus in cases of pituitary adenomas. Do you think the medial wall removal is necessary? And if it is necessary, then how do you do it?
Okay, thank you for the question, Dr. Sankla. I'm doing the removal of the medial wall in functional adenomas. There is some literature now that shows that if the tumor is touching the medial wall, probably there is tumor in the medial wall. But for non-functional pituitary adenomas, we are going to have trouble just if it grows, and we have a lot of time. And I'm not sure if we need to give more complex surgery for these cases, but for functional adenomas, I'm doing. There are two ways to open the medial wall. One of them is following the inferior intercavernous sinus, so the two leaves of Duramada. So we enter there and go to the medial wall. The other way, if you have like the anterior genu of the carotid artery, the proximal part more lateral, you can use the Doppler and do an incision in the medial part that just medial to the proximal part of the anterior genu. If I have a carotid like this is easier than the following the inferior intercavernous sinus, and I do it.
Great. Yeah. Thank you very much. Dr. Kelvin.
You're welcome.
Is Dr. Kelvin there? If not, then I've just asked one more question to hydroxyapatite presentation. I hope he is there. When you do the very good closure and all these things, how do you feel the whole reconstructions when you reopen it sometime, tumor recurrence or something else? How do you feel that?
Yes, we have experienced some revision cases after applications of hydroxyapatite combined with the septal flap. Sometimes it's much more easier to remove the hydroxyapatite. Hydroxyapatite is easily drilled out, and the color is white colors, a little bit different from the real bone. After take off the septal flap and we drill out the hydroxyapatite, it's more white portions, and we can safely remove the hydroxyapatite portions, and then we perform the revision surgery. But the major reason of the revision surgeries may be the intratumoral, intracavity hematoma or other problems, not CSF leak. So there was no problems.
Okay, thanks, Salman.
I think wonderful, brilliant talks and excellent discussion. My question was the same. Like, you haven't seen any complications with the hydroxyapatite DOO-SIK? No
Yes,
problem.
Major problem is we need some overcome the stiff learning curve to apply the hydroxyapatite. It's very similar to the transcranial approaches. Sometimes the breakdown of the breakage of the hydroxyapatite can develop the inflammations or infection source. So it's very important to keep the dry conditions to apply the hydroxyapatite. But sometimes the bloody conditions or the wet conditions, the hydroxyapatite cannot makes that more hardening. It's easily break down in such cases, and then some maybe infections can be developed. We have some experience of infection cases for the pituitary tumor, but mostly we revise and irrigate and then prescribe the long-term use of the antibiotics and medications, steroid medications.
Okay, thank you. Amal, do you want to wrap it up? And maybe Takio can have a last comment, please.
Well, thank you. Great sessions, great talks, really for some of the toughest skull-based conditions. If there's no other questions, as Dr. Sharif said, we'll give Dr. Goto the opportunity to have the final comments on this great session.
Thank you. This session, all members present a very educative or informative presentation. So I think that this session, the success. Thank you for all the doctors.
Thank you. Excellent. Luis, you're here. Did you manage to hear something some discussions here?
I'm in the OR here and try to listen. Wonderful presentation. I'm a little bit worried about something. Endoscopy is not just skull-based. We have more things than endoscopy that we need to show to the young generation that you can do. And craniopharyngioma is not only from the nose. You need to learn the whole, where the tumor goes, where the tumor comes, the size of cella, and another options here. But it's wonderful, the session, very nice videos. When you hope to see in the long-term follow-up at this hydroxyapatite in the nose. I don't know if longer follow-up, you have sinusitis, you have infection, you have extrudes from the nose. We hope not. We hope not. You pray for it. It was a wonderful session. Thank you.
Thank you, Luis. I think I'll get, can you please take over? Yeah, thank you.
Yes, thank you, neuroendoscopy team. Thank you, Dr. Amal. Thank you, Dr. Gutto. And thank you, Dr. Lewis, for joining us. And thank you, all the speakers. Now, moving on, I would like to call upon Dr. Tariq Khan from Pakistan, Chairman of Global Neurosurgery, to move on to our next session of Global Neurosurgery, and Dr. Chloe from China. So please turn on your mics and take over, Dr. Tariq and Dr. Chloe Shia from.
Hi, everybody. First of all, thanks very much to all of WFNS. Thanks especially to Dr. Najia, Dr. Louis Barba, and of course to Salman Sharif and his team for organizing such a huge young neurosurgeons meeting, really. Global Neurosurgery, as you know, is a very new committee, but I think it is catching up very fast and become very, very popular. I am based in Northwest School of Medicine in Peshawar, and with me is co-chair Chloe. Chloe, you want to introduce yourself?
Yes, of course. My name is Dr. Chloe Chia, and I'm a neurosurgical resident actually in Belfast in the UK.
Thank you. So we move on to our first talk. Is Dr. Ernest Bartholomew, and he's from sunny Downstate University, head of Department of Neurosurgery. He's doing a lot of work in global neurosurgery, he's a member of the Global Neurosurgery Committee as well. And also he's doing a lot of work with the Haitian neuroscientists. So please.